In an abnormal functioning or insufficient placenta, the resistance will remain high. This will be reflected by a pulsatility index above 95th percentile for gestational age. Once the resistance reaches a critical level, blood flow during diastole will be impeded, and this is called absent end diastolic flow. Then, blood flow will be reversed back towards the fetus during fetal diastole. This is called reversed end diastolic flow. So, the natural progression seen in a fetus that is deteriorating would be a steady increase in the umbilical artery pulsatility index, followed by intermittent, then persistent absent end diastolic flow, and finally reversed end diastolic flow. A low umbilical artery pulsatility index is of no significance. Some important tips you should know in umbilical artery Doppler. If the pulsatility index is abnormal, you should sample both umbilical arteries and use the more normal value. You should sample approximately at the mid-umbilical cord. Sampling too close to the fetal abdomen may produce a falsely elevated pulsatility index value. Perform Doppler at the start of the examination, and if abnormal, repeat at the end of the examination. During fetal breathing movements, there are variations in the shape of waveforms from fetal vessels. Therefore, Doppler examination should be conducted only during fetal apnea, and in the absence of fetal hiccup or excessive movement. Fetal Doppler ultrasound of the middle cerebral artery is used in two situations. First, monitoring of intrauterine growth restriction fetuses, especially those with increased umbilical artery impedance. In these cases we measure pulsatility index, resistive index, and SD ratio. The second situation is non-invasive assessment of fetal anemia. In these cases we measure the peak systolic velocity. To perform Doppler study of the middle cerebral artery, a transverse view of the fetal brain at the level of the biparietal diameter is obtained. The transducer is then moved towards the base of the fetal skull. Activate color Doppler imaging. The circle of Willis is easily visualized with the MCA is seen as a short vessel running in anterolateral direction. Assess the MCA which is closer to the transducer. Align the MCA flow direction with the Doppler beam. A small sample volume is placed 2 mm from the MCA origin. Optimize the spectral Doppler baseline and PRF to get a large waveform. This is optimized middle cerebral artery waveform, as you can see in this cineclip. Fetal head compression should be generally avoided, as it can artificially lead to decreased diastolic flow in the MCA. Normally, middle cerebral artery has high peak systolic velocity and low end diastolic volume. In normal circumstances, as you can see in these images, the diastolic flow is absent in the middle cerebral artery in the first trimester. With advancing gestation, the diastolic flow is established with low end diastolic volume. The normal pulsatility index of the middle cerebral artery should be above the 5th percentile for gestational age. In fetal growth restriction, there is preferential shunting of blood flow to the fetal brain, known as the brain sparing effect. This leads to increased diastolic flow, and hence reduction in pulsatility index of the middle cerebral artery. A pulsatility index below the 5th percentile for gestational age is abnormal. Middle cerebral artery peak systolic velocity can be used in the assessment of fetal anemia, secondary to conditions such as parvovirus exposure, twin-twin transfusion syndrome, and TRAP. This measurement is reliable from the week 18 of gestation. Anemic fetus will have increased systolic velocity in the middle cerebral artery because of reduced blood viscosity. For the best technique to measure the peak systolic velocity in the middle cerebral artery, it is better to use 0-degree angle of insonation. The peak systolic velocity is measured. Multiples of the median for gestational age are calculated and compared to the gestational age. The risk of fetal anemia is highest when the peak systolic velocity is more than 1.5 multiples of the median for gestational age. During middle cerebral artery Doppler study, care should be taken to apply minimal pressure to the fetal head with the transducer. Because fetal head compression is associated with alterations of arterial waveform and reversal of the diastolic flow in the middle cerebral artery. Other rare causes of reversed diastolic flow include impending fetal death and complex cardiac anomalies. Another measurement that is sometimes used in the assessment of fetal growth restriction is the cerebroplacental ratio. The cerebroplacental ratio is a ratio of the middle cerebral artery flow to the umbilical artery flow by using the pulsatility index values. In calculation of the cerebroplacental ratio, the pulsatility index is preferred over the SD ratio. The cerebroplacental ratio has a greater sensitivity than assessing the MCA or umbilical artery Doppler pulsatility indices in isolation. A low or abnormal result associated with adverse perinatal outcome. Ductus venosus is a small trumpet-shaped connection between the umbilical vein and the inferior vena cava. It carries the oxygenated blood from the umbilical vein to the inferior vena cava. Doppler study of the ductus venosus for aneuploidy screening is performed between 10 and 14 weeks gestation, often in combination with evaluation of nuchal translucency. Doppler ultrasound of the ductus venosus is also performed in the second and third trimesters, when there is a concern regarding fetal growth restriction, and to assess cardiac function and strain in fetuses with high output conditions. To perform Doppler study of the ductus venosus, use color Doppler ultrasound to localize the site of aliasing between the left portal vein and the inferior vena cava. This aliasing is best seen in sagittal plane in the first trimester and axial plane later in pregnancy. The fetus should be at rest and not breathing during ductus venosus sampling. Ductus venosus waveform has three components: the S wave, the D wave, and the A wave. The S wave reflects ventricular systole. The D wave reflects ventricular diastole. And the A wave reflects atrial contraction. The ductus venosus has a characteristic sound. Its sound looks like the sound of washing machine. Listening while sampling is helpful to confirm correct cursor placement. This is the sound of ductus venosus Doppler. Abnormal findings include the absence or reversal of the A wave. This is associated with increased risk of aneuploidy and congenital heart disease. In monochorionic twins, reversal of the A wave is a marker for increased risk of developing twin-twin transfusion syndrome. When reversed A wave is depicted in a fetus with fetal growth restriction, this finding seems to indicate that fetal survival is unlikely beyond 1 week.